presentation. And now for the moment you've all been patiently waiting for. I have the pleasure of introducing our wonderful speakers for this evening. First up, we have Professor Zoe Winters, consultant in general surgery and breast surgery. Zoe Winters holds clinics at the Lister Hospital, Chelsea Outpatient Centre, and Chiswick Medical Centre. After that, we will have a presentation from Dr. Parijat Bhattacharjee, consultant in obstetrics and gynecology, based at the Wellington Hospital's Elstree Waterfront and Chiswick Medical Centre. Tonight's talk is all around menopause and HRT, so I'm sure you'll find it very interesting. But we'll start with our presentations, followed by the Q&A at the end of the session. Now that's enough from me. I'll hand you over to Professor Zoe Winters to make a start.
Thanks very much, Poonam, and thanks, Roxanne. It would be lovely to get to see all the faces behind all the icons, all the letters. So I'm pleased to come and share what I think is an evolving field, and we're going to talk about really understanding risks of breast cancer, both in women that have a family history and maybe different clusterings of types of cancer, as well as how we are going to look at evaluating population risk in our practices, whereby we can better advise the frequency of mammography. And then I'm just going to mention a small amount about HRT, which I'm sure my colleague will take on further. And I think it's incredibly important that a lot of the myths around HRT are now being disbanded. So I find that very exciting because I think it's going to have a fabulously positive spin-off overall on women's health. But of course, that's got to be in the context of, I think, finessed understanding about personal risk, and of course, balancing those benefit-risk ratios. So as Poonam has said, I'm actually exclusively a breast specialist, and my specialty areas are in breast cancer, but also understanding the science of genetics, and I work closely with colleagues at the Marsden in genetics, as well as oncologists at the Marsden, and at furthermore leaders in oncology care and through HCA. And that's obviously a major strength in the team. And so I also have an honorary chair at University College London, and I make it my business within our practice to share the latest medical papers after every consult. And that's all done using a digital online platform that effectively is our practice management system. So our entire practice is digitally transformed, both to GPs. All women get every single report. So we really, I think, happy to share the science around what we discuss, even on a day-to-day basis. Poonam, I don't know if I could switch this, or are you doing that?
I don't know if you'll be able to control the slides, so just let me know.
You're the train driver today.
Yep, I will be indeed.
Go for it. Okay, when I give you a thumbs up, go for it. Are you able to switch that on?
Oh, I can't see your thumb up, but I can just flick through to the next
I'll just give you a thumbs up as in that. So the first thing is, we talk about risk, and I've sort of put this into a context of family history, and the family histories that we focus on now are very different to what we used to look at years ago. And so our criteria for thinking about clustering of genes that may link to breast cancer is super important. And I'll talk about that a little further in subsequent slides. We've all known when Angelina Jolie came to the news about the very highly penetrant, dominant genes. And, we'll say BRCA1, BRCA2, but of course PALB2, which is a relative of both BRCA1.
It's not working on there.
Are you okay there?
Oh, sorry.
So PALB2, can everyone hear me?
Yes, so we can hear you loud and clear. Yeah. Thank you.
Cheers. So PALB2 is a relative of BRCA1 and BRCA2 in the DNA repair pathway, which is defective. And that was only discovered 6 years ago. And I'll make a really important point about that, because women will come to you and say, well, I was tested maybe in 2012 or 6 years ago. That's not good enough. We always recommend retesting, because our knowledge has improved in how we test, the extent of the gene we test, the number of alleles we test, And furthermore, there are other genes we test. So we all know about folks talking about lifetime exposure to estrogen. And of course, when we go on to the discussion about HRT, it's actually estrogen who is the queen of hormones. And in women who take estrogen only, of course, there are many health advantages when they become physiologically perimenopausal. But you know all the things that we learned in medical school about relative risks. And of course, what's come to the fore of late is high body mass index in postmenopausal women. And that postmenopausal fat is an important source of estrogen. And so increases in body fat in postmenopausal women, as you know, is a risk factor for at least 7 different cancers, of which the uterus, colon, I'm thinking as I'm speaking, but certainly breast and probably ovary as well. And clearly there are others. So HRT has had a pariah status, and that's disenfranchised women's health. And I hope that, with Davina McCall and other huge voices in the public sector or the public arena, that as practitioners we are going to start to change our thinking. And there's fabulous editorials that have come out in the BMJ, and I'm happy to share any of the PDFs with you. So if you want any of the papers referenced to which I speak in this talk, just let me know, and I'll share them through Poonam. We know about the types of benign breast changes that, however, are going to place women in a higher risk. And what is that risk? Well, it's quite difficult to contextualize because it's one of many factors, but benign biopsies that subsequently come back as intermediate in their risk, atypical ductal hyperplasia or lobular cancer in situ, is still now put in a category where we regard those women as high risk. But even though we say that, we don't specifically change our screening strategy. And I think probably we should. And therefore, we're starting to use algorithms that bring all these factors into an AI-developed platform that includes other key factors that I'll mention, to be able to decide how often we mammogram women in the population. And we're going to talk a lot about breast density as well, because it's super important. Based on the European Society of Breast Imaging, no woman should have a mammogram without that report containing information on her breast tissue density. And I talk about this every single consult in somebody who's had a mammogram. We talk about breast tissue density, that is the white absorbent image on the mammogram. In other words, breast duct tissue absorbs X-rays and looks white, fat is liquid and looks dark. The ratio of white to dark gives us a density score. It goes from A through D. A is fatty, not a risk factor, the little old lady who's never been on HRT, but remember, density is also genetically determined, versus the most extreme density, which is D. And if a woman has an ACR, that just stands for the American College of Radiology, because the Americans were the first to really, I think, put this at the top of the focus, is that if you have an ACRD, you have a 4 to 6-fold higher risk of breast cancer relative to fatty breasts. If you have a C, that is also dense breast tissue, and therefore we cannot simply rely on mammograms for optimal screening sensitivity. So I'll talk about that a little further, but effectively in a CD score, we always add bilateral synchronous ultrasound, because like dense breast duct tissues, cancers will appear white and we can miss them. If you're very dense, we begin to integrate breast MRI in routine surveillance. Now, to my knowledge, none of this is happening in the NHS yet, but that is behind the curve. So in the rest of Europe and other parts of the world, this is routine. But within the private practice, this is now an implicit part of our reporting by radiologists, how I share those reports with patients, and how we recommend the optimal screening and frequency of screening. We're very interested in what we call background genes. Those are genes that are completely normal at birth, and subsequently, through multiple complex pathways, that's Nobel Prize stuffs, whether it's high body weight, whether it's lots of alcohol. This is just touching the tip of the iceberg, but there is a change in multiple low-risk genes with multiple dysfunctional changes, and these are called single nucleotide polymorphisms. This is big. This is going to be the future of how we identify population cancers, be it breast, be it colon, be it heart disease, could even be dementia. So we actually can now, at the Lister, offer a test called MammaRisk that calculates this polygenic risk score, which is an independent predictor of personal breast cancer risk. And that, alongside breast tissue density, are probably the two pivotal factors that then give you an ultimate score and tell us how often we should, next one, Poonam, we should screen you. Poonam, can you switch to the next slide? Great. So the high-risk genes, the very dominant genes, we all know about them, are the minority. And I say this to women because perhaps their perception is different. In terms of our thresholds for testing, it's not just young onset breast cancer. You can have a BRCA2 gene or a PALB2 mutation, and those cancers will occur in your 60s. So the concept that these are only early cancers is not correct. So of course, we take note of first and second degree relatives, but we don't make it exclusively only young onset. We will simply take a first and second degree relative, and we will refer that woman for genetic screening for what we call germline genes. And that just means genes that were abnormal at the time of the ovary and the sperm recombination. So we absolutely include second degree and third degree relatives and fourth degree relatives. And what's incredibly important now is I ask about all cancers, probably the ones that I'm not as focused on including in my history are clearly in more environmental cancers such as smoking-acquired lung, or either cancers relating perhaps to the esophagus or the mouth and the tongue. And we now really open up a big gambit for what we call extended gene panel testing. And the panels that the geneticists use, you could use, but clearly we want that geneticist analyzing the rationale for which genes are we really homing down on. But if we take a panel like Invitae or Color, it doesn't really matter what the name is. We can test something like 9 genes, of which we'll have combinations of the very dominant ones. Then we'll get intermediate risk ones like CHEK2, and we'll get low risk ones. And I'll talk about why they're important. Because if you've suddenly got breast and then you've got colon, then you may have stomach, then you may have thyroid. We have to test for more extended genes, because if we find one of the intermediate penetrant genes or intermediate risk genes, we can change the way we start screening women in their 30s, and that can reduce mortality. Next one, Poonam. And just a point that I didn't highlight on that previous slide was that there is a paper that I'll also share with the team. I share it regularly with women whom I refer to a geneticist, and that is women having had testing before 2014 should be retested, and that comes from the American Society of Oncology. So this is important. You don't have to remember everything, but we've talked about the germline mutations. They are the minority, but the ability to lower the threshold for testing and to extend what we test could make a massive difference in terms of us even screening women in their 30s. So we are looking for clusters of cancers like breast, ovary, colorectal, prostate, pancreas. And most of you will know now that we take seriously those relatives in families who have a high-grade metastatic prostate cancer or have a pancreatic cancer. And although that BRCA2 mutation is really associated, we've still got to think about it, because if we don't think about it, we're going to miss that opportunity or that window. So extended gene panel testing in all high-risk families, and then thinking about extended gene panel testing when you've got these other cancers that cluster around breast. So when you talk about the key criminals in the plan, the high-risk genes are raising those lifetime risks threefold greater than the population, and these are the big players: BRCA1, BRCA2, PALB2, P53, a rare mutation, and that tends to be associated with lots of young onset cancers. And then P10, the Cowden syndrome, once again rare, but we have had cases with us. What we see more and more now are the moderate risk genes, where our risks are 2 to 3-fold. And I have a young woman with a CHEK2 mutation, not a BRCA, but a CHEK2. CDH1 is part of the Lynch syndrome. So you could get clusterings of colon, uterus, renal. I'm thinking about the others, gastric, STIC11 and BARD1, and I can't quite remember. So that is, let me just get back to that. So I'll come back to that, it'll come to me. So the low risk genes are raising risks 1 to 2-fold. ATM, so ATM, once again, could be linked sometimes to prostate cancers, and so can check also to occasionally, rarely, to ovarian cancers. And then we get these genes, RAD51C and RAD51D, that we wouldn't have even thought of, that are also behind breast cancers. So it's just slipped my mind what STIC11 is, but it's all there, and therefore we, Poonam, can you go to the next slide, please? So this is a fantastic paper by the Americans on extended gene testing, and the really key, headline message here is that if we do this extended gene testing because we've thought about it, because of course we've got to work out who we're going to do it in, but if we might have one breast and then other cancers, and we do pick up one of these intermediate or low risk genes, or even a high risk gene, we will start MRI screening from 30 to 35, and we will reduce breast cancer deaths by 54 to 55%. So, we've talked about those fold differences. From 40 years of age, we would do mammography and MRI. So the concept is, when we're dealing with this whole grouping, which is still going to make us, all these patients, higher risk than the population, either by 3-fold, 2 to 3-fold, or 1 to 2-fold, we should start screening using MRI only from 30 or 35 years of age, and the Americans are favoring 30 years of age. And by 40, we will add mammogram to MRI. So the concept before was never that. It was always going to be, you've got a very high-risk gene, like BRCA1, BRCA2, therefore you're going to add MRI only in that group. That no longer applies. Next one, Poonam. So the role of MRI as a very important ancillary in these types of patients, but importantly, in a different population that is normal, just population risk, we're using it as well in very dense breasts. So this is just taking that same point again, being able to screen women in their 20s and in their 30s with breast MRI. It's not mammogram. So once we've defined risk, and of course I'm really bouncing this off the geneticists scientifically, so from 40 plus MRI mammogram, and now we're probably going to take that up to 60 years, and then the question of density comes in as to whether we're going to continue with annual MRI as we get older. So that's going to depend on the density of the breast, and clearly that's where we're collaborating with radiologists. So the ability for sensitivity is going to therefore increase. Could we flip it, Poonam? So the real surgical risk reduction still is reserved for the very high risk genes, and it's not a one size fits all. And you can see the difference whereby the earlier we advise or recommend or catch and are able to intervene with risk reducing mastectomy in BRCA1, the more we can impact on reducing mortality up until 80 years lifetime risk. So the BRCA1s will get a much earlier onset, and therefore we want to do surgery in the early 30s. For the BRCA2, that's different, and the risks of breast cancer for BRCA2 are a different range compared to BRCA1, and the same for ovarian cancer. So we can't forget the other target organs, but these really are breast and ovary. So the question of a 60-year-old woman who presents with a BRCA2 mutation and shows that she has a pathogenic mutation, if she's 60, the decision-making regarding whether she should have a risk-reducing mastectomy is different to somebody in whom we detect the BRCA2 gene mutation at 40, because you have to look at cumulative lifetime risks from non-breast cancer factors, and so the benefit the 60-year-old gets is proportionately less than the 40-year-old. So that risk-reducing mastectomy doesn't lower mortality to the same degree. It's maybe a 2.6% reduction in mortality versus perhaps an 8.7%. So there's a great paper on the timing of offering skin-sparing mastectomy in the context of the gene. So that's, again, where we work closely with geneticists. Thanks, Poonam. So I think we've covered this. It's just so annoying that my brain can't think. So CDH1 is the classic hereditary non-polyposis colorectal cancer. That was what was called HNPCC. You now, if you're on Twitter, you will see lots of talk about the Lynch Syndrome. So CDH1 is the Lynch Syndrome, and that is where we bring in uterine, we bring in breast, we bring in gastric, stomach, colon, and there's others. So CHEK2 is one of the proteins that controls the cell cycle. So it's part of your DNA repair pathway. And CHEK2 has a myriad of cancers associated with it. It's part of the DNA damage repair pathway. And so you could have breast with CHEK2, prostate with CHEK2, thyroid, and colon. So you can see that when we are in this setting, and when I do the genetic history, which is routine in every single one-stop patient, that if I'm getting clusterings, it's immediate genetic referral. I'm not just focusing on breast and ovary. Okay, so I think that's what I want to say there. Poonam, if we go on, please. Poonam, are you there? So we've talked about PALB2, and there, once again, ovarian, pancreatic, male breast cancer. Lynch, I've made a big deal about that. You see there, renal comes in there too, and brain. That's interesting, because you'll get folks who have the odd isolated brain cancer, and I'm trying to think in my head, you know, if you suddenly had quite a few relatives with young onset brain cancer, you might think about P53, but brain is coming into the Lynch syndrome as well. Hepatobiliary, you know, this is a rare condition to have a Klatskin tumor or biliary, but if I have any doubt, I refer, and clearly very happy to share those kind of contacts with you. So those intermediate risk genes are as important, but in this type of category, we're talking about enhanced screening. In that category, we could also be talking about enhanced screening, not necessarily risk-reducing surgery. All right, Poonam, can you forward that? Move forward on that. Now, this is the part about nothing to do with germline gene mutations. This is about population gene changes. Why do 1 in 8 women get breast cancer? So when I was growing up, we talked about a spontaneous mutation. What does that mean? We talked about, I never refer to bad luck because I kind of want to find a scientific sort of thinking about it. But at the moment, if we take the NHS screening program, it is based on age only. It is not based on personal risk. Of course, age comes in risk hierarchies with a trajectory, as we all know it, from one's 40s in a steep trajectory up to one's 65, 70 years of age. We can now offer a test that is basically a platform algorithm that women complete. It relates to radiologists scoring breast tissue density. And when women say to me, I want an ultrasound only, not a mammogram, this is a perfect opportunity to jump in and say, the mammogram takes a picture of the whole breast, but it is only on the mammogram that we can assess mammographic density. So every patient gets the score. And as we know, that only about 18% of women are going to have extremely dense breasts. But they are the ones we pick out for 2-yearly or 4-yearly MRI. So that's still modeling what the Americans are doing. Basically, you can look back on density 2 years from a mammogram 2 years old, and that's good enough. So we don't have to charge women anymore. We're now pretty ready for prime time at the Lister at Chelsea Outpatients 280 Kings Road. And that salivary test goes off to the Marie Curie Institute in Paris, and we get what is called a summative big gene data set using 76 genes. It takes about 3 to 4 weeks. And together with other factors, be it, this is not a test for women with a high-risk family history. That's for the germline stuff we've just talked about. This is for women 40 plus years of age, so they're in mammogram age, and we want to know what their personal breast cancer is in 5 years. Is it high, intermediate, or limited? Then using European guidelines, if somebody is high risk in the population, we'd mammogram them annually. If their breast tissue is dense, C or D, we add bilateral ultrasound. If their breast tissue is extremely dense on mammogram, we add MRI. If they're intermediate risk, we'd recommend 2-yearly mammography. And depending on their density, the same approach. If their density is AB, they just have their mammogram. If they're limited risk, we'd start mammography from 50 every 2 years. So you can see nowhere internationally are we spreading out the frequency to 3 years. So really, there's a lot of catching up to do. So I can't read my writing there, but it is the principle of including ultrasound in every woman with dense breasts at the one stop, and only those extreme cases would have breast MRI. Thanks, Poonam. This is HRT. So big data sets from an Oxford group, a fabulous paper by Vinogradova in the BMJ. The big message here, and I say this to all women because there's so much misperception out there. The safest estrogen, or the safest form of hormone replacement, is estrogen. Then we have to say, what is the safest form of estrogen? It is transdermal. And that could be different preparations. And that's because it's not metabolized with the liver or the gut.
Zoe,
Yeah.
I'm very sorry to interrupt. I'm just a little bit conscious of time.
Okay, cool.
Yeah, we've got quite a few comments saying it's quite technical, so I don't know if you want to maybe rush through the next couple of slides, if that's okay?
Could I just make it really simple?
Sure, that would be perfect. Thank you.
Safest form of estrogen, or the safest form of HRT, is estrogen only. When we start to add progesterone, it is the progesterone in the combination that raises risks. And basically, what are those risks? Well, they are then contingent on needing to give the safest form of progesterone. And that should either be an intrauterine preparation or intravaginal as opposed to transdermal. And so some of the papers refer to the fact that a transdermal progesterone is not as safe. Clearly, when you're using transdermal or intrauterine, you don't get thrombotic risks. And in combination HRT for more than 5 years, using older preparations that weren't as safe as they are now, you get 9 to 34 extra cancers per 10,000 woman years. So that contextualizes it. If we go to the next slide, please. So it is progesterone that raises risks, not estrogen. And that has been a misperception. So we talk about the safest progesterone, and Professor Isaac Mayonde at Harley Street Emporium has written a lot about the devil in the ointment being progesterone and not estrogen. So the transdermal progesterone patch does increase risk. The benefits that we're getting from HRT are going to be enhanced, and with estrogen only, those are reductions in dementia from 11% up to 26%, and a reduction in all-cause mortality and cardiovascular disease. And that is overwhelmingly significant with estrogen. With estrogen and progesterone, there are also reductions in cardiovascular risks. But of course, we have to be more vigilant with progesterone, and we don't know the true risks now with the latest and safest forms of progesterone. But they may produce maybe for a combination of more than 5 years with estrogen and progesterone could raise risks to 3 to 7 extra cancers in 10,000 women. So in breast cancer, there's no such thing as safe HRT, and that applies to triple negative cancers. So just because a cancer isn't expressing estrogen and progesterone does not mean that HRT is safe. And with current HRT use, if a woman gets a cancer, invariably it's estrogen and progesterone receptor positive. Thanks, Poonam. That's it.
Great, thank you so much for that really detailed talk. As you can see on the screen, these are Professor Zoe Winter's contact details. So if you do wish to, be referred to Zoe, please feel free to make a note of these details. I'd just like to say we've now got our next speaker for the evening, who is Dr. Bhattacharjee. Fab, we've got you there as well on screen. So again, just let me know when you want me to switch over to the next slide. So Dr. Bhattacharjee is going to go through menopause and HRT, and we will save some time at the end of the session for a Q&A. Thank you.
Sure. Thank you, Poonam. Thank you, Raksha. And thank you, Professor Winters. I really learned quite a few things, including the fact that a woman tested before 2014 ideally should be retested. So thank you. And thanks to all the audiences who have left this sunny outside to sit here and listen to us. So without much ado, I'll just start. Obviously, as Prof. Winters said in the very beginning, that whenever we talk about HRT or menopause and HRT in the context, there are a huge amount of myths that are woven around HRT, and that partly has to do with the history that has been there over the last few years, last 30 years or so, odd years or so, and a lot of those myths have been dismantled over the last few years, and many of the studies that Prof. Winters already has mentioned in those slides. Next slide, Poonam. Poonam, can you hear me? Yeah, thanks. So that's it is just to say that there is a huge amount of controversy, huge amount of debate that comes in the moment menopause and HRT comes into the picture, including probably the two commonest questions that arise. One is if it is safe or not, And of course, the safety comes in the context of various conditions from breast cancer to clots like DVTs and stroke. And we'll come to those. And as Prof. Winters already has mentioned about the breast cancer risk, and we'll come to that in more details. But also the other question that quite commonly comes in, both in the medical parlance as well as with women who are on HRT, is how long can we continue? And MHRA, which is the pharmaceutical regulatory authority in a way in the UK, has quite categorically stated that there should not be any arbitrary limit placed on the duration of HRT, and usually, so long as there isn't any absolute contraindication, which could be breast cancer in a way, even though there is a lot of myths around that, as we have seen before, has been dismantled. But other than that, there should not be any arbitrary limit placed on the duration of use of HRT. Of course, there needs to be monitoring, there needs to be risks that needs to be assessed on a regular basis, but we'll come to that again. Next slide, Poonam. So part of the reason, and I'm not obviously going to delve into the history a lot, mainly because of the time factor, but very quickly, I mean, I think part of the reason why there is so many myths around HRT and its use is partly because this is a relatively new stream, in the sense that research has been happening, say, over the last 20, 30 years, and only recently has picked up in a more definitive way. The big epidemiological studies in the 90s, like the Women's Health Initiative and the Million Women studies, they had brought out a lot of data on this, which obviously helped us in bringing HRT to the mainstream, but also that created a lot of worries and myths, particularly with regards to breast cancer, DVT, stroke, and many of those have actually been negated, or at least the risk is much less than what it used to, what was mentioned in the initial studies, when one looked back into a more detailed analysis on the same studies. After 2010, I think in 2014, a paper came out where they analyzed the same old studies in more details and found that the actual absolute risk of breast cancer and the other risks are much lower than it used to be thought of. Now, one reason why there hasn't been much studies before the 90s or so could be because most gynecologists were probably male, like me. But also, I think the more important factor was that that most women did not, particularly when gynecology or women's health in modern medicine evolved as mainstream subjects of specialties. Most women probably would not have lived into their 80s or 90s, or even beyond menopause. The average lifespan in the early 1900s was around 35, 40. Today, most of us who have survived COVID will probably live into our 80s and 90s. So most women will probably live at least one third of their life, if not half their life, without the estrogen hormone, without the major estrogen hormone in the body. And therefore, the impact that the lack of estrogen has on not only the gynecological organs, but in general, on general health, including a lot of studies that are coming up on factors like dementia, cardiovascular disease, and bone health, has a huge impact. And as Prof. Winters mentioned fleetingly there, that we have to, HRT in all likelihood, at least in the near future, will probably become a regular mainstream medication. Could be like aspirin and statins that many of us take on a regular basis. Coming on to the next slide, Poonam. So obviously I'm not going to go into these details, but this is from the British Menopause Society, which is sort of an umbrella organization in the UK that normally brings out various papers and evidences and collates them to say what's in the UK, what would be the general management options, and quite categorically what it states in this statement is that there should not be any arbitrary limit placed on the duration of the use of HRT, and if a woman wants HRT for her symptoms, then usually in most cases the benefits outweigh the risks. course, as I said before, we need to monitor, we need to assess every so often. Nice guidelines suggest we should assess yearly, but the bottom line is that there should not be a limit placed as such. Most evidences and most guidelines, including NICE guidelines as well as the International Menopause Society guidelines, the Endocrinology Society guidelines, categorically states that at least up to 60 years of age. In most cases, HRT is pretty safe, and beyond that also, if we assess regularly, it could be. Next slide, please. Poonam?
Hi, I think there's a little bit of a delay switching slide. It is on the Lancet page now.
Okay, so I'm okay. You can actually go on, sort of gently just roll on to the slides. These are mostly about the evidences, as I just spoke about. That most guidelines do suggest that up to 60 almost is safe, and beyond that, even if we assess regularly, in most cases it is fine. Next slide. So in the UK, we mainly go by the NICE guidelines. Next slide again.
Dr. Bhattacharjee? I think we've lost you for a moment there.
No, I'm here. I can see, but I can only see the NICE guidelines. Sorry about this. And with my limited IT skills, I was too scared to open another window on where I could have the same slides and I could go through them beforehand. So sorry about this.
So we're on the lost generation now.
Yeah, I can
no
see
problem.
It now. I think there is a lag between it. So the lost generation is for the same reasons as I said. Many women have not taken HRT, missed out on that. As Prof. Winter said, that there's a lot of data that are coming out even now that categorically states that it's much safer than it's made out to be, but much more importantly, it has a lot of other benefits like the cardiovascular health, probably to some extent dementia, even though it's limited evidence at the moment, where HRT is beneficial. So 75%, and this is a survey that was done as far as I remember in 2015 or 16, and I have the data where exactly it came out, but I can give you later. And 75% of women on HRT did not have enough information to make an informed choice. 85% were not aware of other alternatives that are available. 20% only accessed specialist services. Less than 15% of women who suffered from various symptoms of menopause only received treatment as such. And as we said before, in the post-menopause, health is affected in multiple ways. It's not just about the hormones and the hot flushes and night sweats and the sleep disturbances that we talk about, but in multiple ways, including heart health, bone health, probably brain health, and so on. Next slide. So we will go on these factors. So I'm not going to sort of delve on this slide itself. Next slide, Poonam. So menopause, as we all know, menopause by definition, and this is more a medical definition, is anyone over 45 years of age who has not had a period for a year. Generally speaking, we can call them menopause, even though there could be many other conditions, many other reasons why one may not have periods during that time. But anybody over 45 years, if they have it, we can more or less safely consider that they have gone through menopause. If they are less than 45 years of age, then we need to do other tests and be absolutely certain that they are menopausal and not due to other hormonal imbalances or other structural imbalances. Usually it's thought of that, obviously, we know that a woman is born with a finite number of eggs, and from puberty onwards, at every cycle, a few eggs are recruited, one egg ovulates, and therefore, by the time one is around 40 or 45, the number of eggs have dwindled. But still, it's thought of that even around the time of menopause, there are probably close to 1,000 eggs left, but they are not enough to get stimulated. At less than 1,000 eggs is thought of as a threshold where they cannot be stimulated by the follicle stimulating hormone. However, it's not just the lack of periods. A few months to few years preceding that, one usually may, or in most cases may, suffer from the symptoms of menopause, which usually they commonly are hot flushes, night sweats, fatigue, body muscle ache, tiredness, sleep disturbances, and brain fog, that sort of issues, even dryness of the vagina, and some urinary symptoms. So this period is called either perimenopause, premenopause, or climacteric. The average age in the UK is about 50 years and 9 months, or 51 years. Obviously, there are genetic factors, there are environmental factors. Smoking is one of them. A family history of early menopause probably predisposes one, but there could be other environmental factors, like if somebody had a surgery or chemotherapy for other reasons, then of course they're likely to have premature ovarian failure. We often are asked whether we can do an FSH to FSH, which is a hormone that is raised in menopause. This is the hormone that stimulates the eggs in the ovaries from which estrogen is produced before menopause, to check if FSH helps. The problem with FSH is it fluctuates a lot during the cycle, and in particular, a woman who is not having regular periods is even more difficult to check the levels and correlate it with the timing of the cycle. Obviously, if someone is less than 45 years of age, then we have to use FSH. And above that, if somebody is, say, on a Mirena coil, on an LNG, on a hormone-containing intrauterine coil, and sometimes we may use it to come to a conclusion, but it's not extremely helpful. Next slide, please. Again, at the moment, I can still see the previous slide, so.
So we've got a graph on the screen now.
Okay, we can skip this. This is essentially what I mentioned in the very beginning, that we are living longer, women are living longer, and therefore most women will have will go through this period of lack of hormones at least nearly 1/3 of their life, if not half of their life. There are many symptoms, and we can come through that to those symptoms in groups and bunches. So next slide again, Poonam. So the commonest symptom that woman presents with is of hot flushes and night sweats. 70% of women would feel that, and that is partly not because of the lack of estrogen so much as because the thermostat in the brain is reset because of the high levels of FSH and the hypothalamus reacting to that. There are, of course, topical local symptoms, which is the urogenital symptoms, which essentially includes dryness of the vagina, pain during intercourse, increased frequency of going to the toilet, of passing urine, sometimes having urine infections, and that is because of lack of estrogen affecting the lining of the vagina and the lower part of the urinary tract. It can affect emotion, mood disturbances, sleep disturbances, lack of concentration and memory. Brain fog is what's commonly described as. And these are the common symptoms. Usually, in most women, they settle within a few months to a few years. Usually, by 5 years after menopause, in most women, these symptoms will subside. But a small minority of women would be unfortunate enough, like 10 to 15%, where these symptoms can be quite prominent even after 10 years. Next slide, Poonam. Among psychosexual symptoms, and I will separate them, of course. Sexual symptoms, as I said, vaginal dryness, quite common. 50% of women during menopause will probably suffer from. Low desire and orgasm, this is a combination of things. It has something a part to do with the mood changes, the sleep disturbances, the social circumstances that might change, but of course lack of estrogen leading to dryness and pain during intercourse, but also a lack of testosterone in some cases that is sometimes necessary for the libido and orgasm as such. Sleep and tiredness can affect it, and there could be male and other social factors, so we should not put everything down to just the lack of estrogen as such. Among psychological symptoms, frank psychological symptoms, temporary mood changes could be associated with the lack of hormones, with other factors, with like social changes, and of course sleep disturbances. But frank psychological symptoms like depression and so on doesn't usually happen just because of lack of estrogen. In most cases, this would happen with women who already have some past history of either frank psychiatric disorders, or at least a very strong history of anxiety and depression. Lethargy and tiredness does augment the symptoms, sleeplessness worsens it, and relationship and other factors do affect it. Next slide again. Poonam. So again, the local symptoms, as I said, the lining of the vagina and the lower part of the urinary tract are sensitive to estrogen, and their health depends on estrogen. And therefore, the lack of estrogen not only thins out the lining of the womb, the lining of the womb, as well as the lining of the vagina and the lower urinary tract, but the vagina normally contains a combination, an ecosystem of bugs that usually helps maintain a neutral equilibrium there. And that's called microbiome. That's the bacteria, the fungus that lives there, and other organisms. Now, obviously, because of the lack of estrogen, the predominant bacteria, that's lactobacillus, that lives there, is decreased, and therefore the other bugs that are normally not predominant can increase in numbers, and that itself can have an effect on the local health. Recurrent urinary tract infections can be common because of the laxity of the structures and the weakness of the structures down below. Incontinence and prolapse, vaginal prolapse, can become more evident and more prominent now. Next slide. The other long-term risks, so these are the symptoms for which most women would seek help, seek HRT. But there are long-term impact of the lack of estrogen, and the commonest one that we knew of for a very long time, and many women are on HRT because of this, is osteoporosis, which is thinning of the bones, thinning of the bone density. And there is a higher risk of fracture that increases, particularly in the hip and in the vertebra in the back. It is obviously more prevalent in women who already have a risk factor, predisposing factor for weak bones, which could be genetic, which could be low BMI, women who have had early menopause and not had HRT, smokers, sedentary lifestyle, and women who suffer from chronic disease or has been on long-term steroids, which all of these can weaken bones and increase the risk of fracture. Next slide. The other long-term impact of estrogen is, of course, heart health, which, as Professor Winters mentioned before, that there was a lot of myth around estrogen, progesterone, and its ill impact on cardiovascular health, on the heart and the blood pressure and the rest of it. But overall, it's been seen. Next slide, Poonam. Yeah. So there are the previous one, the heart one. There have been multiple papers that have come up over the last few years that have categorically stated and shown that estrogen actually is important, and the hormones are actually important for cardiovascular benefit, for heart health. Cardiovascular death is still the leading cause of death, including in women. Obviously, it increases much more after menopause. Before menopause, it's actually protected. Women are protected more than men because of the hormones. Of course, there are other factors like genetics, high BMI, alcohol, smoking, high blood pressure and lipids. But estrogen does protect to a great extent before menopause, and women who have premature ovarian failure, premature menopause, are particularly vulnerable to having cardiovascular disease and heart disease later on. And therefore, one of the most significant reasons why any woman who has gone through early menopause should have HRT is more to protect the heart and prevent death from cardiovascular disease, even more so than protecting the bones. Next slide. There are many papers, and I'm not going into the details for lack of time at the moment. So investigations. What investigations should we do around the time of menopause? As I said before, FSH doesn't help much, so in most cases we don't do it. Any other hormonal tests would only be done if it is relevant, like thyroid hormones and others. Lifestyle issues, common lifestyle issues like blood pressure and all, should be measured. Bone mineral density. Now, this is one thing that may be relevant in any woman where we suspect that they could be at high risk of fractures or osteoporosis, and a bone mineral density would help and ideally should be done, and the need for additional medication determined on that. The risk of blood clots has been decreased drastically with the use of transdermal estrogen. So the patch or the gel, that does not increase the risk of blood clots and thereby the risk of stroke. And therefore, as Prof. Winter said before, if we are to use estrogen, the safest estrogen to use is that goes to the skin and bypasses the liver, which is either the gel or the patch. And of course, breast cancer screening, which we have already heard before. Next slide, please. So again, the treatment. So if the main reason why the symptoms, whether the short-term symptoms of hot flushes, night sweats, sleep disturbances, mood changes, or the urogenital symptoms, or long-term problems like bone loss and cardiovascular protection, the main reason why it's happening is because of lack of hormones, and by hormones we mean it's estrogen. And therefore, the ideal treatment always is to replace estrogen. Of course, there are certain conditions like somebody having a history of breast cancer or a very high risk of breast cancer where we may not use estrogen and we may look for alternatives. But estrogen is the ideal replacement, if any. Of course, it's for vasomotor symptoms, which are hot flushes. It's the most effective. For urogenital symptoms, which is for topical local symptoms like dryness of the vagina, recurrent urinary infections, incontinence, pain during intercourse, topical estrogen is extremely effective, which means estrogen cream or estrogen pessaries in the vagina are extremely effective and they're extremely safe. The studies that have been done were done with Vagifem tablets, which are pessaries, because they're more, the dose can be controlled much better than the cream. And with 25 milligram of Vagifem, when taken, used over a year topically, the amount of estrogen, the serum levels, the blood levels of estrogen were almost equivalent to a week's dose of oral tablets. So practically the amount of estrogen that is absorbed when one uses topical estrogen, local estrogen in the vagina, whether it's pessaries or cream, is minuscule or nothing. So it's extremely safe. One can use it, and one can use it in addition to systemic HRT that one is taking. Of course, it prevents bone loss, it protects the heart, and it probably protects the mood, even though the studies were not that robust. Next slide, please, Poonam.
Dr. Bhattacharjee, I'm so sorry to interrupt you. I'm just very conscious that we've come to 7:30, and I know we've got quite a few questions that have come through.
No, whatever you prefer. I'm happy.
So, Raksha, did you want to do a quick Q&A before we maybe close the session?
Yes, I'd love to, because we've got so many questions. Well, thank you both, Professor Winters and Dr. Bhattacharjee. Most insightful. I've had texts, emails already from many of the attendees, as well as questions on. So I'm going to start through by going through as many as possible, and I appreciate that after a long day you've taken the time to come and talk to us, really. So I've got a question from Jacqueline. Jacqueline says, I have fibrocystic breast. I'm still getting breast pain. Should I be worried?
No, not at all, Raxan. I talk a lot about breast pain, maybe hundreds of times a month. And there's a great systematic review, which I'm happy to share with a practice. And breast pain is benign 95.5% of the time. So really, what is the cause of individual breast pain? It's largely idiopathic. That means, in medical terms, we don't exactly know what the cause is in each woman, but there are multiple hormonal factors that can exacerbate it, and that can be, for example, the pill, either Mirena coil, some form of exogenous hormones. It could be antidepressants that raise the prolactin levels, and the cells that are predisposed to biochemical hypersensitivity lining the breast ducts become more hypersensitive, and we don't know why. So pregnancy, breastfeeding, HRT, IVF, antidepressants, but it's a misnomer. At the end of the day, it's not linked to breast cancer. Treatments relate, I go into a discussion of the treatments, and I think there's still quite a lot of treatments bandied around that are not evidence-based. So I'd be very happy to discuss. Firstly, I would not be concerned But I think, like anything, I would suggest, a consultation, an imaging review, but largely that is about information and helping women inform them how to examine their breasts and really putting them in the picture with the fact that cysts are part of age-associated change in the ducts. That's also genetic, and that probably that's not a direct correlation with breast pain. So it's probably unique to that particular woman, but it is not a risk factor for breast cancer.
Thank you. Thanks, Professor Winters. Jacqueline, I hope that was useful. I've got a question from Anne M. What testing should be done post 5 years of having breast cancer? I worry about mammograms going back to 3 years, as mine was discovered in between routine checks.
Yes. So in the context of breast cancer, our view is obviously a little bit more flexible in the sense that we realize the NHS has a diktat, but that's just one of my oncology colleagues, I'm so sorry, that in principle, if possible, and of course I don't know the type of cancer, the age of onset, the background factors, but in principle, I want to do annual mammography for 10 years and then go to a 2-yearly rolling program. But I realize there's pragmatism. The NHS are releasing folks at 5 years, and then they're going back into a clinical nurse specialist or a nurse practitioner-led follow-up. And that is the limitation of the system being overloaded. That doesn't mean that we think that's a Rolls-Royce approach, but obviously every breast cancer is different. The point I would make is no one should stop mammography ever, because in a low-risk cancer, you can get recurrences up to 20 years or 30 years post-event, and that's not to worry women, but it's to make sure we've got that kind of safety net, that we understand very low-risk cancers can recur way into the future. So we mustn't be complacent.
Thank you. Thanks very much again. I hope that was useful, Anne. I've got a question from Mags, and this might be for Dr. Bhattacharjee. He says, does progesterone thin the uterine lining and therefore protect against uterine cancer?
Sure. So the HRT, which is hormone replacement therapy, is to replace the hormone that is the root cause of, or the lack of it is the root cause of most of the symptoms, whether the short-term symptoms or the long-term problems of, as I said, heart health or the bone loss. It's the lack of estrogen that leads to most of these symptoms, and therefore the hormone that needs to be replaced to counter these is estrogen. The only downside of using estrogen only in women who have a uterus still is that the estrogen will increase the thickening or thicken the lining of the uterus, the endometrium, as you rightly said, the lady who asked the question. And therefore the role of progesterone in HRT is only and solely to thin the lining, to oppose the action of estrogen on the endometrium, on the lining of the womb, and keep it thin, so as to reduce the risk of developing womb cancer. Yes, that's the only reason to use progesterone. And as Prof. Winters said, the safest form of progesterone is either the coil, the Marina coil, or any. At the moment that's the only one licensed to be used, because it is topical, it is local, so the effect is maximum, and the side effect is minimal because very little gets absorbed. Yeah. Or the Utrogestan as a vaginal recipe.
Thanks for that, Dr. Bhattacharjee. Of course, and then we've got Tash following on that says, should therefore patients request the Mirena coil or intravaginal Utrogestan rather than oral tablets?
Ideally, yes, because the tablets, first of all, from an estrogen point of view, see, previously, a few years ago, there were practically two main contraindications or relative contraindications or absolute, whichever way you call it, for the use of HRT. One was the risk of clots, venous and arterial clots, which included stroke, and that of breast cancer. At the moment, with the transdermal estrogen, which is the patch or the gel, the risk of stroke or the DVT has been practically excluded, or stroke. The risk is less, much less. But the progesterone still was a factor, so that's what we came to. And therefore, yes, the estrogen should be transdermal, ideally always, which is the gel or the patch, and the progesterone, the Marina coil or the Utrogestin pessaries. Yes, ideally that should be the combination.
But then Mags goes on to say she's still a bit confused because most cases of breast cancer, she felt, were traced to the use of estrogen and progesterone.
I think Professor Winters might be better placed than me, but that was part of the myth that we all grew up with.
Okay. So it could be really helpful to share some of the papers through Poonam that I cite to women. So I think, I loved your talk, I don't know how to say it, your para, I'm going to say parrot. So clearly, the devil in the ointment or the fly in the ointment is the progesterone. Now, what we don't know, in fact, Para's done a fabulous iteration of what he would say are the safest forms of progesterone. What we don't have are long-term data on the risks of breast cancer when we're taking now the safest forms. But there's some recent editorials saying that, okay, if we take a big cohort data, you would get, if you took that combo, and these were old combos, you would get 9 to 34 extra breast cancers in 10,000 women years. Now, that's using the old administrations. Now we're coming to the newer approaches to safer progesterone and estrogen. We anticipate that these long-term risks are going to be slightly lower, but we're also saying pragmatically, let's bring in 2-yearly mammography. So that's a very pragmatic approach. Of course, we could then say, let's do this mamma risk test at the baseline. Women take their HRT. What's happening to the population genes maybe 5 years down the line? I don't know, because the scientists that have developed this in Paris, I haven't posed that to them. But you could argue you could check out your population genes and what they're doing as a consequence of these preparations. But pragmatically, I'd be very happy and reassured with women under, the expert opinion of their menopause specialists, such as Para, having that plus your enhanced breast screening. So we've got a kind of a real safety net going on there.
Well, thank you very much, Professor Winters. I've got a question from Vanita, and we're nearly there, where she says, having gone through menopause, are there any benefits to starting estrogen now? She's age 57 with the last period at age 48.
Sure. So first of all, since we brought this, actually my following slides were actually delving on that. So I'll very quickly, briefly delve on this. There are studies to show that, so first of all, why would one want HRT? That's the question. So if it is for the symptoms of hot flushes, night sweats, sleep disturbances, and so on, then of course, if one really is desperate and needs HRT and thinks it is due to the lack of hormones, then of course it's entirely reasonable so long as we assess that there is no other risk factors and one can continue. From a cardiovascular, from a heart health, there are studies, and it would have been on my slide after that. It's been seen, and there is a very nice randomized trial from Denmark of over 4 years, where women who started HRT around the time of menopause, so what they call as early HRT, so early onset HRT, around the time of menopause, presumably around 50s, it was seen quite categorically, and they actually did sort of CT angiograms of the various arteries to see whether the plaques that would lead to more cardiovascular ill health developed. And they found that women who started HRT early on actually were protected. So the development of these plaques in the heart and the vessels were delayed. However, if one did not have HRT for 5 years or 7 years or so and started HRT late, then actually in those women it probably does not have a beneficial effect and may even have a harmful effect. partly because the plaques would probably already have formed, and therefore on top of that, then adding the estrogen and progesterone may have a harmful effect, even though these are early days. But of course, if somebody needs HRT at 57 for just the symptoms, then for a reasonable period of time, the safer forms of HRT can be entirely reasonable.
Oh, thank you very much. I think we'll round up there. I think after a very long day, we're very, very grateful for you both for doing this. Thank you, Poonam. Thank you, Anjana. Thank you, HCA. I'd just like to also thank the partners at Florence Road Surgery who've been very, very supportive. I know we've got Dr. Lund with us today. Thank you, Daisy. And well, thank you to you all, the audience, for listening. Can I pass it all back to Poonam, who will round off? So thank you.
Thank you. Thanks, Roxanne.
Thank you all so much. Just echoing what Raxa said as well, I just want to say a big thank you to Professor Winters and Dr. Bhattacharjee for the excellent talk, really informative talks. I just want to say a massive thank you to our audience as well for taking the time to stay on that little bit extra for the Q&A as well. I really hope you all found it very useful. We will share some details with Raksha to send out. So Zoe, if you're able to send me the papers you think would be useful, you can always attach that as well and get that out to the audience. But once again, a massive thank you to Raksha for organising this patient talk. I hope you all did find it useful, and we look forward to hosting a few more in the future. Thank you all again. Have a wonderful evening.
Thank you. Lovely to meet you all. You take care. Thank you, Kara. Thank you, Roxa.
Thank you, Prof.
Thank you so much. You take care. Bye-bye.
Someone should have raised their hand. Was there someone